All right. Good morning, everyone. It's a great pleasure for me today to introduce the talk of Alice Cavolo and their colleagues. Probably only Alice will present, but this is a joint work on artificial placentas. A little bit about us. This webinar is hosted by Nobumpnocare. We are an international platform for perinatal care to support people and issues in perinatal care. We are organizing these webinars that are verging on different themes and issues in perinatal care. Today, we are thrilled to introduce Alice Cavolo. Alice has a background in philosophy and bioethics. She did a PhD on ethics, on the ethics of resuscitation and non-resuscitation decisions for extremely preterm infants at Leuven, KU Leuven, Belgium. And now she's doing a postdoc on the ethics of artificial placentas between the University of Zurich and KU Leuven. If you have questions on the YouTube platform, you can just type in. The floor is all yours. Thank you, Alice.
Thank you very much. Thank you, Susie, for having me and for introducing me. So as Susie explained, I'm going to today provide an overview of what are the various ethical issues and potential ethical consideration when it comes to artificial placentas. So I'm doing something slightly different from the previous presenter because I'm not sharing my own personal experience. First, because I've never been pregnant, but also because artificial placentas is a new technology. It's not really here yet. So we are actually talking about something that is coming very soon, but still in the future. So we'll start with a quick introduction of what is an artificial placenta, and then the core part is going to be an overview of what are the ethical issues in the literature. I do have an article, so if you want, you can also read it, but to try and make this seminar a little bit more interesting, I will integrate the issues in the literature with my own take and my own reflection on it. And I would conclude with what is missing, I think, from the debate. So starting with an introduction, I know it sounds very backward, but it is actually easier for me to explain how an artificial placenta works if we start by understanding who it is for and what type of problem it tries to address. So it is primarily meant for extremely premature infants born 22 and 25 weeks. Now, in the slides, we will always say EPIs. It's not meant to be disrespectful. It's just shorter. And 22, 25 weeks, if you're not using counting in weeks, corresponds roughly to the very end of the 5th month and the very end of the 6th month of pregnancy. So you can see it's very, very early. I put a picture of preterm baby on the slide, so you can see these babies are indeed very tiny. They're very underdeveloped, and they do need an awful lot of care to be able to survive. Now, they can have a plethora of different issues, but the biggest problem at this point are the lungs, because at this point in pregnancy, the lungs are not really meant to function on their own, and they do need the resuscitation to survive. Now, resuscitation is rather successful, but mortality is still very high. And we also have a lot of morbidity. And importantly, a lot of this morbidity is really a direct result, not of prematurity, but of resuscitation itself. So to make a practical example, if you are trying to intubate most babies, as you can see, the one in the picture will need intubation at these weeks. And if you're trying to intubate someone that is literally this small, it's very difficult to do so without scarring the lungs. And this can really create chronic respiratory issues. So this is really where artificial placenta comes in. So this is a schematic of an artificial placenta. I know that you can see a lump in the drawing, and that might be a little bit weird, but that's because at the moment it's still being tested on animal. And apparently the lambs are the ones that have the closest respiratory system with humans. So it's been tested on lambs. So the whole point of an artificial placenta is to really mimic the human placenta, to allow the lungs to keep on developing as if the child wasn't even born. So in case you don't know, the lungs when in a fetal stage are actually flat because the fetus is not meant to breathe air, and the oxygenation happens through the umbilical cord. Yes? Okay. Sorry. The idea of an artificial placenta is to try to maintain the baby in a fetal stage. So you can see the lump is immersed in a synthetic amniotic fluid. And indeed, it's cannulated through the umbilical cord instead of the classic intubation. And the oxygenation happens with an external oxygenator. If you are any way familiar with intensive care, think of it as a glorified ECMO, basically. So few things to consider. So first of all, should this system work? The idea is that basically we are bypassing the need of resuscitation because the lungs keep on developing on their own. And by the time you can remove the child from the artificial placenta, the lungs at that point are developed enough that they don't need the resuscitation anymore. One thing to consider is that the soul system is maintained by the fetus, or at this point, the child heart. So there is no an external pumping. It's the heart of the child that actually pumps the blood in and out. So it's, let's say it's oxygenated externally, but it's the own child heart, which also means that we can't really use this technology before 22 weeks, because before you simply don't have a heart that is strong enough. Also, this is only meant to last for a few weeks. The idea is not to leave a child inside an artificial placenta forever. The idea is to basically gain a few weeks of time to allow the lungs to be stronger and to tolerate the regular intensive care without resuscitation. And finally, for the whole system to work, we need a C-section because we need to place the child in the artificial placenta fast enough that the child doesn't start breathing, because the moment they start breathing air, the lungs inflate, the circulatory system sets, and everything basically sets, so you can revert the system and go back to an artificial placenta. And the only way to prevent that is to go with a C-section, because the moment the child is going in the birth canal, at that point it's too late. So now, what it can and cannot do, I'm not going to stay a lot of time on these slides. We touched most of these points already. It will improve the chances of survival, ideally, and lower the risk of morbidity. It could be used maybe for other at-risk patients. It's not really clear, though, because this is still going to be a very high risk kind of technology. And artificial placenta will solve one of the problem of prematurity, but there's still a lot of problems, as you see, they will still have very high risk of death and disability regardless of artificial placenta. The most important point for me is that an artificial placenta is not an artificial womb. So if you have the idea that this could maintain an entire gestation in an artificial environment, it cannot do that. We simply don't know enough of what happens in the utero in the first trimester to be able to replicate it. And on top of that, this is a technology that targets fetal physiology. So you need a fetus. You cannot apply it to an embryo. And it's not as simple as simply making it smaller, as someone believes. You will need to have an entire new technology from the get-go. So not to say that we will never have an artificial womb, but this is not a first step for an artificial womb. So when it comes to the literature, we did identify 3 macro groups of ethical issues. The first one, we called it foundational ethical issues, because those are more philosophical issues that really relate to the essence of what it means to be human, or in this case, what it means to be a child. So there is a huge question in the literature of whether artificial placentas will create basically a new moral entity that we never had before, and what should be the moral, legal, and metaphysical status of the artificial placenta subject. Now, from the fact that I always called it a child, I think it's pretty clear that I do consider it a child, and I will explain in a moment why. But it is fair to acknowledge the fact that this is not a universal position. Actually, the literature here is very evenly split between those who consider it a child and those who consider it a new category called gestateling, which is something that is somewhat in between a fetus and a child. Now, the reason why someone thinks that this is going to be a gestateling is because although it is outside of the human womb, like a child is, at the same time, it still has fetal physiology. Because as we said before, crucially, the lungs are still in the fetal stage, the respiratory system is still the fetal stage, the circulatory system is still fetal. So for all intents and purposes, this is physiologically a fetus, right? It is outside of the human womb. Now, the argumentation is, of course, a lot more refined and complex, but for the sake of this presentation, this is really the core point. Now, I think it is important to understand where these people come from, because if you understand what is the background, it comes quite easy to understand why they take one position or the other. So the main proponent of the gestating theory and the one that really founded these theories are Elsalin Kingma and Chloe Romanis. Now, Elsalin Kingma is a philosopher, and she works a lot on the metaphysics of pregnancy, and she has a very convincing argumentation of why we should consider this as a gestating. But she really talks about metaphysics, so she doesn't really enter in the nitty-gritty of the clinics. When it comes to Chloe Romanis, she's a lawyer, and we know the law needs very clear category, because depending on the moral status of the subject, different law apply. And in most countries, a fetus is not a child. Very different law apply to these two categories. So if I can imagine a situation where you have a judge that has to rule on a case with an artificial placenta subject, then they need to know what moral category this is, because they need to know what law apply. So again, from a legal perspective, it does make perfect sense that this is a new category that is somewhat in between, because indeed it's neither one or the other. The one like me who take the infant position are actually all people that comes from either the clinic, so they are all physician or clinical ethicist. And for us, the perspective is very different, because what we consider is really the care that you're going to provide. And there is not enough differences between a preterm in an incubator and a preterm in an artificial placenta to justify treating them differently. And on top of that, technically, already with the preterm and definitely with the 22-weeker, you can make the argument that it's physiologically more similar to a fetus. But we know that when doctors take that position, parents are deeply hurt. Not all parents would consider them their child, but most parents in an active treatment choice would consider it their child. So the position that we take is a little bit more nuanced. We can agree that from a physiological point of view, that is a gestating, but in a clinical setting, then it's a gestating that we treat as an infant unless the parents ask otherwise. So the second big cluster of questions are reproductive issues. And here we have three main questions. The first one is, can we use it for non-medical reasons? And here we have, again, two camps. We have the first camp that says, yes, we should actually allow pregnant people to choose an artificial placenta regardless of any medical needs. And the main reason here is rooted in autonomy. Pregnant people are autonomous persons. Artificial placenta requires a C-section, which is an intervention on their body. It's a mode of delivery. They should be allowed to choose what type of interventions they want on the body, including an artificial placenta. Who says no roots it more on the best interest of the child, or future child in this case. Because this is, again, is a very invasive, is very high risk. And on top of that, you need to account also for the risk of prematurity. And they say it's simply too risky to allow to use it for no medical reasons. Now, my 2 cents on this debate are actually somewhat in between this position. Now, in an ideal world where we have infinite resources, I'm actually not against the idea of using it for elective reason, regardless of medical reason, even for no medical reason, because of the autonomy argument. The most important for me would be that the pregnant person, though, is aware of the implications for the child, because it will have implications. So they need to be aware and they need to accept them. Not to say that we need to terrorize them and to kind of push them into rejecting it because of the child, but still they need to understand what it will mean to have a child in intensive care for a few months. In a real world, though, where we have limited resources, I think it's still important to remember that this is first and foremost a medical treatment and potentially a life-saving treatment. So I would still be inclined in agree that we need at the very minimum a list of priorities, and we should give priority to those who need it for a medical reason before giving it to those who don't need it for a medical reason. That said, though, where I would add to the literature is that I wouldn't only focus on the medical needs for the child, though. We saw in previous seminar that the pregnancies can be very traumatic. There can be very severe complications when it comes to pregnancy. So I think it's when the pregnant person has a medical reason, especially if severe, that should count as a medical reason to have an artificial placenta. It's not only the child that counts, especially because there is an intervention on the pregnant person as well. Of course, there is a whole debate on what counts as serious enough. I'm not trying to solve it now. Of course, that has to be discussed as well, especially if you want to set some priorities. But that's just to say that we shouldn't look at only at the child. The biggest issue is actually, should we use it as an alternative to abortion? Again, we have two camps here. And you have some people, thankfully are not that many, but they're very vocal in saying that we should actually use it as a compulsory alternative to abortion, or at this point, a new method of abortion, because it would allow to respect the pregnant person autonomy, because they can still interrupt the pregnancy. And at the same time, we could save the fetus. And here I'm literally using their words. Those who say actually we shouldn't say it for many, many reasons. But again, to try and narrow it down to make it more manageable in 30 minutes, the main reason is that when it comes to the technology that we have, this is actually extremely harmful because we can only use it around 22, 23 weeks. This would mean obliging someone to stay pregnant for way longer than they would have wanted to. And on top of that, we are obliging them to have a C-section, which is very invasive, even compared to surgical abortion. So if we look at the clinical ethics, it's an infringement on autonomy, it's an infringement on beneficence, it's an infringement on normal maleficence. There is no justification to assume that. And even if, let's say, this is not the case, artificial placenta is super safe, you can use it at any point of pregnancy. These authors still maintain that abortion is a basic healthcare need that should coexist with artificial placenta. So point being, a person should be free to choose whether they want to have an artificial placenta instead of an abortion and then put the child in adoption. But this should, again, come from the pregnant person. It should be enforced. I guess it's pretty clear where I stand on this point. I do completely agree with those that say it shouldn't be an compulsory alternative to abortion. What I find it interesting, though, is that I've seen a few scholars saying that actually it could be it could be the only way of having an abortion in countries where abortion is completely banned at the moment. So in those countries, could improve reproductive rights, but again, this is an extremely problematic position. So yeah, just to say that it's there. So the bottom line question here is artificial placenta going to improve or reduce reproductive rights? Again, I think it's pretty clear from the bipolar presentation that I gave that actually per se is relatively value neutral. Is really how we are going to use it and how we are going to regulate it that will determine the outcomes. So this is not to say that we can just say it's value neutral and move on, because this debate is extremely important and it does show that we need to have this discussion to implement it and regulate it appropriately and beforehand to be sure that we are maximizing the outcomes that we want and minimizing the outcomes that we don't want to. That said, though, it's also that is not going to be enough. I do agree with those people who point out the technology itself can create a pressure. We see it with any other life-sustaining treatment. Just because the technology exists, people feel compelled to use it, sometimes even when it's not in the best interest of the patient. And this is not going to be any different. And on top of that, we already know that pregnant people are already pressured into choosing treatments that are in the best interest of the fetus, not necessarily on their best interest. Easiest example is surgery. That is a big intervention on the pregnant person. And we know that a lot of people feel compelled to go for it. This is not necessarily only an external pressure from, for example, the partner or the family. It can also be internal because they feel that to be a good parent, they have to choose for that. They have to sacrifice themselves. So it is important that we are implementing it and we are training healthcare professionals. Then we also need to train them to be aware of the risk of internal and external pressure, to see the sign, and to be able to address the issue should it arise. The last, big group is a research ethics issue, and those kind of overlap quite substantially with clinical ethics issues, actually, so I kind of merged them together. The first big issue is what it's going to actually look like. Here I put some examples, some prototypes that are being developed. They're all being developed by different groups. The one on the very bottom is actually the prototype from the group of which some of my co-authors are in the same paper. And what it looks like might not look like a typical ethical issue, but in reality, it really can be. Because here we really need to thread a balance between what is technically feasible, what are the interests of the parents at this point, and what are the interests of the child. And it's not that easy. To make a practical example, there is a huge discussion on whether it should be transparent or not. Because from a point of view of the parents, probably transparent is going to be better because they can see their child, they can have at least some sort of contact with their child. But for the child is actually not that good because at this point, a child is not really meant to be outside of the womb, so it's not really meant to be light, and light is very, very harmful for them. So for them, a more blacked out solution would be better. So what they're trying to do, that's why you can see like the opaque balloon on the right. The idea is to have something that is opaque enough to shield the child as much as possible from light, but transparent enough that parents can still see the child. So these are the kind of trade-offs that they are trying to make. Then we have a huge problem when it comes to selection of participants. So the first point, I think this is pretty obvious, it's going to be what are the children that we are going to admit in the trial. And now here again, we have two options. It's a very bipolar situation. So the first option would be to have smaller preterms. So these are the ones that have really the highest risk of death and very severe complications. So for them, the trial could be justified on the basis of compassionate care. This could be their best chance to survive. So this could be a good reason to have the trial. On the other hand, they are also extremely vulnerable. So that, on the other hand, could be more difficult to justify having an experimental treatment on such a vulnerable population. And also, they might not give you the best data. This might sound very callous, but we are doing a trial to have good data to be able to generalize it to the whole population, to know if this treatment is actually going to be good enough for this infant. So if we don't get good enough data, then it means that we harmed the participant in the trial for no good reason. So this is actually an important point. And they don't give you the best data mainly because at 22 weeks, they are really, really much more similar to a fetus. So it's very difficult to generalize this population. On the other hand, we could go a little bit older. They have a much higher chances of survival already. So for them, the artificial placenta could be a really, really a good treatment. But at the same time, it could be a lot more difficult to justify a risky treatment for a population that already has good chances of survival. Now, the problem, though, is that here the literature doesn't really take a position. They just show the pros and cons. So we did actually in a different paper, but we proposed to stop looking at the gestational age, to just look at the risk factors and to have basically a two-stage trial. First, you include only the babies that have the highest chances of death, regardless of gestational age. In this way, you can still use the compassionate argument, which ethically is the one that makes more sense. But you will also have some 24 and 25 weekers, so you will also have a better sample. And then if that works, you can, of course, expand the trial to also all children that have better chances of survival. We also need to remember that the pregnant person is also a trial participant in their own rights. So there is also discussion on how you select parents as well. Here, someone proposed, for example, to only include parents for whom C-section is already indicated, because at least that means that you're not adding the risk of C-section, because they're going to have it anyway. But this could also be an infringement on autonomy. So this is quite a contested proposal, actually. The one that everyone agrees on is that, of course, parents need to have counseling. What is crucial in this setting is that counseling should also include what are the risks for the pregnant person, but also what are the rights of the pregnant person as a research participant and later on as a patient. And finally, only people that also had the time to elaborate the information and make a decision should be included in the trial. So what is missing from this whole debate? The biggest problem that we had actually is that this debate is really, really imbalanced. I only present what are the main issue, but to give you an idea, we are out of 40 papers, we only had 12 that actually looked at the trial and clinical implementation. Everyone else considered either fundamental ethical issues or ends, because mostly the same author, what are risk for reproductive rights. And the problem though, and even actually the one that looked at trial and implementation, again, mostly conflate the two moments, which is not really good, because some of the issues of the trial are not necessarily translatable. Some you can translate, like some points of counseling are going to go for both moments, but other elements are not easily translatable to the clinical setting, and the other way around. You have issues of the clinical setting that don't necessarily translate to the trial. And even when you talk about the trial, we see that a lot of the time we have very generic advice. Things like you should counsel parents, you should respect the autonomy of the parents. These are things that go very important, don't take me wrong, but they go for any kind of trial. They're not specific of artificial placentas, but this is a very unique technology that has some very unique aspects. Most and foremost, the fact that you have two patients whose interests can be in conflict. So the uniqueness of this trial and the uniqueness of this clinical implementation should be discussed as well, especially because we will have trial and implementation before we will have use of artificial placenta in the broader society. So it's important to discuss them quite urgently. So our point, just to be clear, is not that we shouldn't discuss reproductive rights. Not at all. It's important to discuss them as well. Our point is that we need to have a more balanced debate in which we have both discussion, not only one or the other. The second big gap that we identified is the involvement of stakeholders. We noticed that kind of everyone was sticking to their own field. So that was a big first issue. You have developer that mainly talked about really like the device development and what were the results of the first round of testing on animals. And then you have the lawyers that tend to talk a lot about regulations. You have the philosophers, but like no one was really interacting with each other, which is very problematic in this aspect. And also there was no involvement of stakeholders. So doctors and parents were basically almost absent from this debate. Now, I'm very happy, and it's one of the reasons why I wanted to point it out anyway. I'm very happy to say that by the time that in the between the article and this presentation, this gap was actually quite filled. So now we see that there is a lot more involvement of the community. There is a lot more debate, and now a lot of research groups are actively involving experts in biolaw. They're actively involving ethicists in their own research and development, which is very good to see. And there are also quite some studies on parents and healthcare providers' perspective. What are their needs? What are their expectations, and so on. Not everything is out yet. Not everything is published, but a lot of these studies are running, which is important. So I think it's important to point it out. We shouldn't only complain. It's important also to say when people do things right. And the last big issue that is quite completely absent is fairness and equality, especially when it comes to access. So this we see some discussion of fairness and access, but that again is in a context of discussing elective use of the technology. So there is concern that, for example, minorities will not have access to it, that only traditional family will have access to it. I would also say sometimes they kind of, again, they kind of mix the technology. They talk about artificial placenta, but they're really more talking about an artificial womb. So the debate there is also not super clear. but again, it's completely missing from the clinical setting. And the reality is, first, we already have massive injustices when it comes to cross-country access to healthcare, because we talk about the resuscitation of extremely preterm infants, but in reality, the most part of the world, I would say, still cannot systematically resuscitate these infants because they don't have the resources to do so. Not because they can't do that, not because they don't know how, but because they physically cannot. They don't have um, enough resources really to be able to do so. And this means that we are making the NICU in very high income country more and more sophisticated, more and more effective, which is not bad inherently, but then the gap with the rest of the world is becoming even bigger. And this is also true within country, because we already know that unfortunately, people from low socioeconomic status and people of color tend to have lower survival rates and lower and higher rather morbidity rates compared to white infants. And this is already not okay. And one of the biggest issue, there are many factors that explain this, but one of the main factor is the fact that the NICU is already very high tech, is already very expensive. You don't have it in every hospital. And typically people that come from low socioeconomic status and people of color tend to live in areas where you don't have a hospital with a NICU, which drastically reduces the chances of survival. Again, artificial placenta is going to be very expensive. It's going to be very rare. Even less are going to have access to it. So this is also a type of access that has to be discussed. And finally, we have a very, again, we touched it a little bit on the clinical trial, but that's also going to be on the clinics. As with any new health technology that has been introduced, before becoming part of regular care, think at dialysis, now it's part of regular care, but at the beginning it wasn't. It was very rare, it was very expensive. You need to understand how you're going to prioritize it. Even if you just say we give it first to the people who have a medical need, how are you going to make a priority in that group? So are you going to give it to the one who have needed the most, so the one that have the higher risk of survival, or are you give it to the one who might make the most out of it because you don't want to waste it, so to speak, a resource? These are not easy decisions to make, and you can make a very good argumentation for both of them, but we have to make a decision, and that has to be done before we start using the technology. That was it. Guess I hope I've been within the time. And here I put a few extra references just in case someone wants to see them and to read more. And thank you very much.
Thank you, Alicia. It was fantastic. Can you stop the sharing?
Sharing.
We can see
Yeah.
your face. It was I'm
Yeah, it
deeply
worked.
grateful to yeah to have you here, because how else would we come in contact with such important topics?
Thank
So
you.
really, really grateful. I open the floor to questions and discussions. So just jump in or let me know if you want to talk.
Hi, can I say something?
Of course.
Of course.
Well, thank you very much. That was a fabulous presentation, very
Thank
informative,
you.
very clear, very informative. I really, really enjoyed it, and I feel very privileged to be here. Uh,
Thank
um,
you.
Let me just introduce myself. I'm Aline Ferreira. I'm from Portugal. I'm writing a book on artificial wombs, but fictional representations.
Oh,
So
that's so interesting.
yeah, but your presentation, of course, brings out all these bioethical issues, and of course, I'll have to address them as well, but not with this depth that you're bringing to it. So it's very, very interesting. But so you're a clinician,
And now I'm a philosopher.
a philosopher. Okay, okay. But do you have information about when a clinical trial might begin, like with the artificial placenta that was used for the lambs, but when it might be, because Partridge and their team in Philadelphia, they were saying they might start it really soon, right?
So it depends on the groups. the group of partridge in Philadelphia indeed is the one that is the furthest away. In fact,
Yeah, that's
that
what I
is also
thought.
the one why we have the most information about it. They are very close, actually. I think in the next 2 to 3 years at this point is going to happen.
Yeah,
They already had preliminary discussion with the FDA, because it's the US, so it's the FDA that regulates the trial,
yeah,
to understand how to organize the trial, how to do it ethically, because it's going to be a difficult one.
yeah,
So they are very close. Some others are a little bit more in the middle. So I guess it's going to be, let's say, to take it big, like in the next 5 to 10 years.
yeah.
And it's the group in Barcelona. It's the group. There is a group between Australia and Japan that are
In
working
Japan.
together,
Yeah,
and they are working. They are already testing on animals, but they are a little bit earlier
yeah,
than partridge. There is a group in Michigan that is doing something very, very complicated. They are quite before, but they are really trying to make it feasible, even if the child already started breathing. So that's super complicated. They're very early. And then the one in the Netherlands, as far as I know, they are the
yeah.
earlier ones.
Very
So
nice.
there is going to become very, very late. But again, they are trying to do something very complicated. They really want to make it compatible with vaginal delivery, because in the Netherlands, they were saying most of this delivery come through
Yeah,
vaginal delivery.
yeah,
So if you only have a C-section, then you're cutting out a lot of people.
yeah,
Um, so they are designing a completely different system, and it's taking them a longer time. They
yeah,
also have less funding, I think. So
yeah. So surely it'll be the Philadelphia team, probably.
the
That
Philadelphia team is
their
the
firm.
one in pole position at the
Yeah.
moment. Yeah, yeah. As far as I know, they're also the only one that really have started the discussion for the clinical trial. They started the
Mm,
applications and
yeah,
so on.
exactly.
So yeah, they are really the ones that are very, very close. The other ones are in the making.
Yeah, yeah. Thank you. Yes. That
No
was great.
worries.
Thank you so much.
Thank you.
I was thinking in terms of bioethics. At some point, you raised the problem of basically principlism. So
Yeah.
having principles of fairness, autonomy, justice, but then they don't give an answer to the case by case, because it can be everything and it's
Yeah.
not. Yeah, which is the problem of the principalism we have in bioethics. And I'm working to create. I mean, now I'm working to create a handbook of phenomenological bioethics.
Mhm.
And I'm trying to push the idea of it might be worth it to apply some, look on the lived experience before doing bioethics. I mean, instead of creating general principles and then apply them, force them, squeeze them on life, start on the other way around. So maybe taking more time, but having a phenomenological approach that is lived experience based. What do you think? Would that work in the case you are studying?
So you're preaching to the converted here, because I completely agree. I should say that
Yeah.
I actually really like principles, though. I think I might be one of the very few, but I think that a lot of
Okay,
time
tell me. Yeah, yeah, even better.
I
Yes.
think that a lot of time the problem is more how it is applied, rather than what I should say, dogmatism principlism. And the book is actually a lot richer than people give it credit to, and it's a lot more flexible than people give it credit to. So I think a lot of time, if it was applied, used correctly, we would solve a lot of the problem of the criticisms that comes to it. That said, it's not a foolproof uh, framework, as there are always limitations. There will always be cases in which it doesn't work. When it comes to using more empirical data, though, there I completely agree. I do actually have quite a problem with philosophers who kind of assume what people want or do. I think this idea that you need to have one or the other, it doesn't make a lot of sense to me. You can easily have both, and you can have a circular movement, sorry, in which you can start from the lived experience, do the theory, and move back to the lived experience to kind of refine the theory. And you can go on like this, because no theory is ever going to stand forever the test of time. You will always need to readapt it based on the changes, on new technology, new politics, new scenarios, new everything. So I think that you should be very, very much complementary. When it comes to new technology, that becomes slightly trickier, of course, because it's difficult to talk about the lived experience of an artificial placenta when you don't even have it. One way, and I hope they follow this right, they are already starting to do that with clinical trials, to include already, let's say, qualitative study, to understand what are the lived experience of the people undergoing the trial as well, so that they can also learn that side that can then inform how to refine, let's say, more soft parts of the intervention. So counseling, for example, support in general for, in this case, parents. So I really hope they're going to follow this route as well. What we did, because I have to say, after this paper, I worked a lot on trials. My co-authors worked more on implementation. What we did when it comes to trial was to try and look at comparable scenarios. You cannot find everything, but you can find a lot. So for example, for the trial, we looked at the maternal fetal surgery trials, because they have in common the key elements that you have two participants. That was a big one, and also they have in common the fact that you can test it directly on the fetus, because they both target fetal physiology. So you cannot do what you typically do with children, that you test it on adults and then you do it on children. It's impossible here. So we looked at those trials to see what were the issues there, what were the lived experience of the people as well, to try and see what could be the issue in the artificial placenta trial as well. And in fact, we found a lot of things that were not found in the literature simply by applying like the 4 principles. So that's one way. Similar for the counseling, you can look at, we have a ton of literature on prematurity that we can look into to know what parents prefer in terms of counseling, what makes them supported, what is bed support, and so on and so forth. So there is still a way to look into lived experiences and to integrate them. You just need to be a little bit more creative, but it's not impossible.
Beautiful, thank you. I think it's it's a nice a way to put the problem, to view it in a circular model. And the ethical issues you raised are chilling.
I know.
Big problems ahead, especially again for women and reproductive rights.
Some of them took everyone by surprise. I think the abortion, actually, no one, even the developer, for example, were completely taken aback, and they took it very badly, actually, because they were saying, we never thought of that. Like, that was never our intention. This is not what we are thinking yet. But that doesn't mean that this is not going to happen, unfortunately, just because that's like, I believe that this is not, I met few of them. I know that this is really not their intention. Like, they are honest there, but yeah. That doesn't mean that, unfortunately, someone will not propose to use it that way.
Yeah, that's true. Other questions or comments or our excellent speaker?
Can I say something else? I was just wondering if you could provide some clarity about the terms artificial placenta and artificial womb, because in the literature I often come across both, and one can be a bit confusing, because, for example, with the partridge and the lambs, it's an artificial placenta, but but
they call it artificial womb.
But they call it artificial womb. And then if you think about an artificial womb from the beginning, from the the embryo stage, you need a womb, but you also need a placenta, I suppose. So it's a bit confusing, don't you think? Or
It's
what's your
very
opinion?
confusing.
Oh,
Yeah,
okay.
it's one of the points that we raise in the article as well, that the terminology is hella confusing. And
Yeah,
there is a lot of terms that often means the same things, often not. Um,
yeah,
so I think it's some terminological clarity is important.
yeah,
Generally, I intentionally use artificial placenta. I try to make it as simple as possible for people. Romanis, for example, use artificial placenta and amnio technology. It's very correct. I think it's just a little bit more complicated, and
yeah,
I like to keep it simple. But I do it intentionally because I want to draw a distinction. And talking with parents, I saw how harmful it is to create this confusion.
yeah.
And also, when you read the debate on the abortion, it stems out of this confusion to the point that, which I very much respect, one of the author, um, Christopher Stratman, he actually afterwards came back and said, well, no. My argument was a very theoretical argument in the case we have like a really super safe technology, not for the technology that exists at the moment. So this confusion is very harmful. I think at the beginning they called it artificial womb. They didn't think a lot at it.
No, I think you're right.
And
Yes.
some revert back. So, for example, Joanne Werwey, which is also one of my co-authors, but she's a maternal fetal specialist and she's involved in the group in the Netherlands. They actually said, well, that was a bit of a mistake. We should have probably just called it artificial placenta, not to create confusion, and also not to give false expectation to parents that they might think that you can use it at any point of pregnancy. Unfortunately, if you have a miscarriage within the first trimester, you cannot use an artificial placenta. So some of them, like really, I think most of them now are going towards like, let's call it an artificial placenta, or to just use the name of the technology. They have different names because that has to be on the patent.
Yeah.
The group in Philadelphia, I have to say, they are quite stubborn. They didn't take criticism very, very well. um, I think they were a brilliant group. I don't want to be undiplomatic, but I think on this point they really want to call it an artificial womb, and they have all their reason that it's all related to the technology,
Yeah.
and they insist on wanting to call it artificial womb because it's more correct to the technology. And I think on that they are kind of not taking enough into account what is the actual debate at the point on what is the actual scenario. So I personally think that it's very harmful to call it an artificial womb. So I like to use a distinction, and I always make it an artificial placenta is for preterm babies or from fetuses, and an artificial womb could be ideally for everyone at some point,
Yeah.
maybe. Who
Yeah.
knows?
Absolutely. Thank you. Yes, I agree.
I hope it helps.
Yes, absolutely. Thank you.
Other questions, comments? I'm checking out also the people on YouTube in case anyone wants to write anything. Well, meanwhile, thank you, Alicia. This was fantastic.
Thank you.
Yeah, I have no words, and it's wonderful to see how prepared you are from so many perspectives. So we really have the person to go for questions in this very niche topic. Yeah.
Thank you.
Thank you very
So
much.
maybe,
Okay.
yeah, maybe people who will watch the video later, if you want, if anyone at some point have question, they might ask you.
Yeah, I'm of course always available. I think there should be my institutional email somewhere, right?
Ah, yeah,
So
the
it's,
first slide.
yeah. Also, there are not that many Alice Cavolo in the world, so it's very easy to
So you're
find me.
covered. Good. Good for me, yeah. It helps. All
So yeah,
right.
it's very easy to reach me. I'm always willing to answer the questions and to
Wonderful.
have a discussion. You can very easily disagree with me, and I'm always happy to discuss.
Anzi, yeah, the disagreements are always are often better. They bring in new ideas.
Oh yeah, absolutely.
All right. So Thank you all for being here today, especially you, Alicia. And Aline, this brought a very interesting perspective in the discussion. Thank you so
Thank you.
much. And see you. Yeah, we have one last meeting before the summer break. It's going to be on being a spider woman. So we will work on the importance of having a network in perinatal care. And Emanuela De Bellis will be our presenter. Again at 9:30 on Friday, 9:30 Pacific time, of course. All right. Thank you so much. Have
Thank
a
you.
nice weekend,
Thank you.
everyone.
Thank you.
Thank you.
Bye.
And Aline, we definitely need to talk.
Yes.
I'm so curious to read your book now.
Well, it's still being written, but I'm getting there. Thank you.
You're welcome. I'm very curious.
Bye bye.
See you.